Good afternoon, everyone, and greetings from Manchester. Today, I'll be speaking to you about diabetic foot infections, its assessment, and some aspects of the orthopedic principles of management. As far as diabetic foot infections are concerned, when you assess a diabetic foot ulcer, it's quite important to know that you have assessed the patient as a whole, the medical history, the relevant comorbidities, the current medications, previous history of ulcers and amputations, duration and type of diabetes, the previous hospitalization. All of them are quite relevant in your assessment. The first and foremost is the vascular assessment of the patient. I use an acronym called VIPS, which stands for the vascular condition of the foot, the presence or absence of any ischemia, the presence or absence of an infection, any pressure points in the foot, and lastly, the sensation. So this slide shows you what my acronym for that assessment would be, and that is VIPS. The vascular assessment itself is fairly important, and I'm sure that other speakers are speaking to you about it. But things I look for would be the pulse, the ABPI, the toe brachial index, and the Doppler assessment. Why is this important? I think it's crucially important. If you're managing an ulcer operatively or even non-operatively, the actual vascularity and the tissue perfusion is quite important for this ulcer to heal. And there are studies that show that there are some thresholds above which healing is better and below which you probably should get a vascular opinion or your ulcer may not heal. Now, as far as the infection itself is concerned, there are a few cardinal tests which are useful for you to know as to whether or not there's an infection. The ones I use include a positive probe-to-bone test. A foot ulcer being present for more than 30 days is likely to be infected and also have osteomyelitis, history of recurrent infections or recurrent ulcerations, and lastly, any traumatic foot wound, someone stepping on a nail, someone stepping on a stone and developing a wound. I think unless otherwise proven, you should accept this as being infected and treated with respect. The important thing is that in diabetes, the diagnosis of infection must be clinical, not microbiology. Just because you had a negative swab, if you have a wound which is not healing or is suppurating or pouring pus, you accept that is infected. So all open wounds are generally colonized, and a positive culture is sometimes hard to interpret. So you should be getting deep cultures, deep tissues be sent away for sampling. There is some evidence for this. The main thing here is that if you have got a diabetic foot ulcer or a suspected infected foot ulcer, then doing wound swabs is absolutely of no use because they will grow something and which may not be relevant for your treatment or for the patient. You should be looking to get deep tissue samples by curating the wound. Alternatively, look for a tissue biopsy, and lastly, aspirate if there's any pulse or any collection underneath. And also, if you got a probe-to-bone test, which is you can feel bone to the ulcer, assume that there is osteomyelitis and also bone infection, and you may be able to get a bone biopsy to send away, which will be quite useful for you and also will help you make that diagnosis and drive the antibiotic treatment. Now, the management of these ulcers requires a holistic approach. I'm an orthopedic surgeon, but I think my role in this is fairly limited compared to the people I work with and the wider team. It requires a holistic MDT approach. You won't have optimal diabetic control, so you need the physicians on board. You need to have effective local wound control and care, so you need a nurse on board. You need to get infection control, so you need to have your microbiologists working with you. You need to have pressure relieving strategies, so you need to have plasters, offloading, podiatrists on board so they can help you try and manage the patient as a whole. And lastly, but not the least, you need blood flow. You need the foot to be vascularized, so you need to be speaking to your vascular surgeon. So it's a team approach in managing this, and that's something that I hope you'll take away from this talk at the very least. Now, what do we know about diabetic foot infections? We know that they are generally polymicrobial in nature. And as time passes, you get increasing numbers of infecting organisms and species. To start off, these are simple infections. They are gram-positive and they become gram-negative, subsequently become mixed synergistic, and lastly, when gangrene sets in, you get anaerobic infections. This is the cascade. As you can see, initially, the ulcer itself is a neuropathic ulcer, and as time passes, it becomes more of a neuroischemic picture. And the infecting organism profile and number also changes. So depending upon where you're intervening, you should know what type of infective organism might be causing the problem and try and target that. Okay, we generally send tissues to labs to see as to what is growing, but most labs do not use PCR or molecular methods for identification of what is infective organism. So this is a nice study which was published a number of years ago, which shows the type of organisms which are normally seen in diabetic foot ulcer. So the circle A shows the ones which are very common, the ones that we normally look for, and circle B shows all the other smaller organisms which we do normally test for because they're not generally relevant in most normal people, but may be relevant in a diabetic patient, especially if they've got low immunity or don't have the ability to fight that infection. Now, the main thing is that although I showed you a number of organisms, it's not possible to treat all of them in one go. The key thing is that one more concept I want you to take away from this talk is the head of snake concept. Generally, in these, the soup of organisms, if you want to call that, there is generally a predominant pathogen which is either methicillin resistant or methicillin sensitive Staph aureus, which drives an infection. You also would find gram-negative rods and obligate anaerobes. So if you target the head, okay, you target the head of the infection, or rather the leader of the infection, then generally you'll find that you can control that infection and the body or the rest of the infection withers away. So the key thing is that even if the cultures yield multiple organisms, you find that your swabs give you a plethora of organisms, treat the likeliest pathogen. So you generally can focus your treatment with a narrow spectrum antibiotic, even in polymicrobial isolates, as long as you know what you're treating. So generally, how do you manage these? So antibiotic therapy is generally indicated in most cases, but we know from experience that this is generally not enough to cure severe infections. That's because most antibiotics we currently use have been around for 30 plus years, and the infection spectrum has changed, the patient profile has changed. The initial treatment generally would have to be empiric. You look at the infection and start some antibiotic therapy depending upon what's available and what's in your local formulary or your local guidelines. And the definitive treatment needs to be based on your sending specimens away and the cultural sensitivity and speaking to your microbiologist. And again, I would say even if the cultures yield multiple organisms, you treat the likeliest pathogen. The key thing is that do not give antibiotics to clinically uninfected ulcers because you increase resistance. And also, if you actually carry on giving antibiotics beyond what is required, you also increase the problem of resistance and the fact that the antibiotics may not work on the patient the next time they come back to see you. Now, there are lots of good published protocols regarding how to choose an antibiotic and how to treat them. I'm not going to go into that. I would ask you to look into this and also look at your local guidelines in your selection of antibiotic and how long you give it for. But the key thing here is that how do you assess the response? So ideally, if you have an infection control and the wound heals, that's really amazing. But the key thing also, you need to take on board not all patients tolerate all antibiotics. Sometimes you need to change the antibiotic. And also if you get a poor response, you may need to increase your antibiotic coverage or add more antibiotic to it. And also if it's not working, look at the circulation, go back to what I spoke to you about before, the VIPS approach to it. Go back, speak to your MDT colleagues, speak to ID, speak to micro. The key thing here is that, yes, antibiotics are great for diabetic foot infections, but we want antibiotic stewardship. And the key thing here I would like you to take away again from this talk is that I would like you to start smart, start smart, and then focus your antibiotic therapy for the particular organism. So how long do you give antibiotics? So there are lots of studies on this. There's a really good study, if anyone wants to look it up. They looked at over 1,000 patients and they found that there was no real threshold for an optimum duration or route of administration of antibiotics. In the sense, IV or oral does not make a difference. The length you give it for does not make a massive difference, provided that you're on the right therapy. And also, there are studies, especially the Oviva study from Oxford, has shown that oral antibiotics is not really inferior to intravenous therapy. So the question is that, do all of them need to be admitted? Do all these patients need IV antibiotics, or can we get away with oral antibiotics? I think the question is still unanswered to some extent. But the key thing here is that we do find that patients do get repeated infections despite antibiotic therapy. So there is a problem. So you find people coming back with repeated episodes of ulceration, either in the same foot and sometimes in the same area. So I don't think we're winning on this just yet. The reason for this is twofold. Number one is that if you look at the microbial profile of diabetic foot infections, the amount of resistance in most common organisms in diabetic foot infections seems to be going up over the years. It may be that we are to blame because we are treating more with antibiotics. And secondly, also important is that if you get osteomyelitis, most antibiotics have got a very low bone penetration. Vancomycin is an excellent antibiotic. We use quite commonly in my hospital. You can see that only about 10% of the antibiotic you give the patient, the vancomycin you give the patient, actually gets to bone. So that means that it does not work very well if there's bone infection. I think to explain this, I need to take you right back to how infection is caused. The basic concept is that you can get abscess formation. Secondly, what happens is the bacteria decide to work together, form a group, and work in cohesion by forming a biofilm. This is what a biofilm looks like. So you can see how the bacteria suspend in the biofilm, they talk to each other, and they try and work together to try and beat the antibiotic. So these are bacteria encased in a shell, and they produce that matrix themselves. And once they do that, they can actually form little colonies, and from the colonies they send out bacteria which can seed other areas. Now these biofilms, or aggregations of bacteria, if you want to call it that, exhibit both resistance and tolerance. Okay, so that's why we struggle to control the infection just simply with antibiotics. Now, the last and the most worrying thing, especially an orthopedic surgeon, is that sometimes the bacteria invade the bone directly at a submicron level, kill the bone, and then actually colonize the bone. In these circumstances, it becomes almost incurable. That's why when you get osteomyelitis, you get recurrent infections over years sometimes, which becomes hard to treat. So this is what it looks like. It uses the bone shell and essentially lives inside the bone shell, and they can survive there for very long periods. So how do you treat the biofilm? So maybe prevent the biofilm, that's really good. There are lots of coatings and local application of drugs and antimicrobials coming into food, which I'm sure others will speak to you about. But biofilm is important. You need to try and prevent the biofilm. Secondly, you want to remove the biofilm. That's where my rule comes in, which is we do debride, to remove any implants which there, and to cut it back down so you get down to good tissue. But the problem is that if you have got bone infection, how much do you resect? If you resect more, you get better control of infection. Or you resect more, there's little function, or there's no function because you've taken too much off. And we all know amputations are a good thing. All that gives you excellent disease control. And the last thing is that the new thing that we are thinking about and trying to work towards is to penetrate the biofilm. How do you get through the biofilm? How do you beat those bacteria? And the only way of doing that is to have a battering ram. You want to break through. And the only way of doing that is to have higher concentrations of antibiotics locally, which you cannot give by IV or oral. It has to be local antibiotic therapy. Remember, local antibiotic therapy. Okay. Now, debridement, you can see that's how a debridement should be. Okay. It needs to be thorough. It needs to be down to good tissue, and it needs to be complete. You're trying to get rid of the biofilm. You want all the dead tissue to go. So this is another example here. One of my colleagues have sent it to me. Very innocent looking abscess or a collection. But do you think that's enough? No. Do you think that's enough? No. Do you think that is enough? Still no. That is what is needed. Okay. So it started off being very simple, but there was deep infection, trapped on the tendon sheets, and that is a complete infection eradication by debridement, and that's what gives you disease control. But the problem here is that the more you take out, you end up with a foot that is not really functional. And what we want from surgery is that we want a functional, stable foot. We want someone to be able to wear a shoe, and you want to leave whatever you leave behind being durable. They should be able to walk. There should not be any bony prominences which lead to more ulceration. And the problem here, especially in the foot, is that sometimes the surgical cure will be at the expense of cosmesis and function. So leaving something like that is pointless. You can see that the surgeon has taken off a number of toes. There's good infection control. The wound is healed. But you can imagine that foot is not chewable, and the patient will struggle to walk. And if anything, those two toes which have been left behind are functionless, will get caught in something, and they'll come back with an infection later on. So perhaps that should have been a tarsal amputation or more proximal amputation. So you need to think. It's just not a matter of cutting away the dead tissue. So as I told you, we've been working over the years with local antibiotic therapy. This is an area which I've got a lot of interest in and I specialize in. So we have published a couple of papers on that, which you may be aware of or may want to read. One is about managing calcaneal osteomyelitis using absorbable, locally applied calcium sulfate and gentamicin. We also looked at the totality of diabetic foot osteomyelitis and how to manage this. And these two papers have been well received, and they've been available for a while now. So you can see here, this patient has got a first tray osteomyelitis. You can see excision and application of local antibiotic beads. Similarly, this gentleman has got midfoot osteomyelitis. You can see debridement, reconstruction, application of local antibiotics, and how it goes on to heal quite nicely. I'll give you a similar example, quite a bad one here, calcaneal osteomyelitis, debridement, bone excision, partial calcanectomy, drill holes into bone, and then local antibiotics applied by a silo technique with eventual healing. The key thing is that if you are meticulous and if you know what you're doing, you can achieve excellent cure rates and excellent ulcer healing. And sometimes in the right patient, with the right team, I would say, the right surgeon, the right team, the treatment and the results can be comparable to non-diabetic osteomyelitis. However, there are problems. Soft tissue cover is an issue and vascularity affects your treatment. So I'll take you right back to my first slide with VIPS and the vascular assessment of these patients. Thank you very much.